Welcome to the Deep Dive, where we crack open the source material and give you the distilled insight. Today, we have a really fascinating document. It's not your usual academic paper. It's actually a medical memoir from someone who's seen both sides, physician and patient.
That's right. We're looking at key parts of Banyan tree, expecting the unexpected, by Dr. Padmavathy Guthikonda, a retired physician. And the title itself, Banyan tree, gives us this great metaphor. The tree's big canopy, that's the clinical wisdom she gathered over years. But then you have the aerial roots, right? They represent the strength, the kind of unconventional insights she got from being both a doctor and someone dealing with really chronic, quite debilitating pain.
Right. And our mission for you listening is to really trace how she developed this very specific and honestly pretty revolutionary theory. It connects what seems like subtle, ongoing spinal strain to this whole cascade of chronic health problems. We're talking everything from headaches right up to, well, serious neurodegenerative diseases. So we need to unpack how she thinks this progression works and look at the treatments she suggests, which are quite practical, but definitely not traditional. So let's jump into the source. We're looking for the very start of this idea. Okay, let's unpack this. Starting with the literal physical event that planted the seed for this whole banyan tree theory, 4 decades ago?
Yeah, she pinpoints it pretty clearly. It happened right when she started her career as an employee health physician. And the physical trigger, it wasn't something dramatic like a fall or an accident. It was just needing to kneel down to do cardiac compressions, for a CPR recertification course.
Just the standard requirement.
Exactly. A common physical task.
And the key thing, which is really central to her whole argument about subtlety, is that the change wasn't instant. She mentions the symptoms started showing up maybe 2 months later. And very quietly at first, initially just feeling like she needed more rest in the morning, unusual fatigue.
That slight shift then started to grow.
Yeah.
About a month after that, she began needing strong support just to get comfortable enough to sleep. And she gives this really specific detail, which kind of sticks with you. She found the only way she could get truly restful sleep was by lying flat on the carpeted floor.
Wow, just the firmness.
That firmness was the only thing that gave her body relief.
That need for extreme firmness, that's a huge clue, isn't it? About some kind of underlying mechanical issue.
For that, definitely. And the discomfort eventually sort of focused into pain in her lower back. Like a lot of doctors, probably. She initially tried treating herself using pain medication samples from pharmaceutical reps.
The usual stuff.
Right. It worked for a bit, but she knew right away this wasn't fixing anything. This was just masking it. She realized she was heading towards chronic pain and had to figure out the root cause.
And she described this really tough period, forcing herself to work through what she calls great difficulty for 3 whole years.
3 years. Imagine that. Pushing through significant discomfort, trying to keep up professionally, until the pain just became completely unbearable.
That kind of sustained pain, it led to a total breakdown, basically, required bed rest. And the recovery sounds brutal. She mentions dosing off for 22 out of 24 hours a day.
Utter exhaustion.
Yeah, after 3 months, she could walk again, but the low back pain was still there, and now she had severe pain shooting down both legs, too. So that's when the specialists came in.
And this failure point, this is where the theory really started to germinate. She gets referred to a spine specialist. He orders an SSE test that's a somatosensory evoked potential test. For anyone listening who isn't familiar, it basically measures how fast electrical signals travel along your nerves, from your limbs back up to your brain. Checks the nerve pathways.
Okay, so testing the wiring. And what did that show?
Well, it showed something pretty serious. Severe neuritis in both legs.
Neuritis, so nerve inflammation.
Exactly. Severe inflammation along those pathways, likely the sciatic nerves. And based on that specific objective finding, she underwent the standard invasive treatment. 3 rounds of cortisone injections put right into the joint connections between the vertebrae. They did this over 3 months.
The standard approach. And did it work?
Nope. Complete failure. Zero relief.
Wow.
Which basically forced her back onto her own simple regimen, but more importantly, it pushed her to start doing extensive reading, trying to synthesize an explanation. This is the aerial route, the patient experience driving the physician's research.
Right, because the standard playbook failed her.
Precisely. She realized there was this critical gap in her medical training. She knows that all the years of med school and residency, they didn't really give enough exposure to the full pathophysiology, the detailed functional changes behind a disease.
How things actually work or go wrong.
Yeah. Specifically, They didn't teach enough about how these kinds of musculoskeletal conditions start subtly, how they progress slowly, sometimes over decades, and the complications you get if they aren't managed well early on.
That missing narrative, that beginning to end story, that's what drove her to search for the ultimate starting point, which led her straight to this core idea: subtle cervical strain in the neck.
Her insight is that the initial spinal strain happens really subtly. It starts when the weight of your head isn't properly supported by your neck muscles because, fundamentally, they lack the strength. This constant low-level mechanical stress kicks off a chronic inflammatory reaction,
Yeah.
but it builds up silently, often without any obvious symptoms right away.
Okay, so a hidden inflammatory process driven by a mechanical weakness in the neck. How does that then turn into symptoms people actually notice?
Well, she thinks it depends a bit on the person's body. For people who start with pretty good muscle strength, that continuous, unbalanced stress makes the neck vertebrae slowly compress over time. Then the body tries to defend itself. The muscles tense up chronically, trying to stop more compression, trying to stabilize things. And that chronic tension, she argues, is what most often shows up as a classic tension headache.
Ah, the super common tension headache. She's saying that's actually a sign of underlying cervical compression.
That's her argument. It's the body's first, often ignored, warning sign.
And if people just pop pills for the headache and ignore that signal, what does she think happens next?
She asserts that if the tension headache is just treated symptomatically for years, the underlying mechanical issue, the compression, the inflammation, it just keeps going. And that cumulative damage can eventually degenerate into a migraine headache.
From tension to migraine.
Yes. So her clinical view is that treatment really needs to target the root cause, the cervical strain itself, not just chasing headache relief with medication.
Here's where it gets really interesting. Because she doesn't stop at headaches. She connects this to other conditions that seem, well, totally unrelated.
Right. She believes that if you catch and treat this cervical strain consistently and early, you're not just preventing headaches, you might actually be preventing conditions like carpal tunnel syndrome.
Carpal tunnel. How does neck strain connect to the wrist?
The implication is nerve pathway impingement or irritation originating higher ups, affecting the nerve function downstream. And she also includes hand tremors, specifically what she calls essential tremors.
Neck strain influencing hand tremors. Okay,
Yeah.
that's already broadening the scope significantly.
And it comes the boldest claim. She argues that if the cervical strain continues unchecked, progressing over decades, the inflammation and compression can ultimately degenerate into chronic neurological disease, potentially leading to Parkinson's disease.
Wait, hold on. Parkinson's. That feels like a huge leap. We're going from neck muscle weakness and vertebral compression to a neurodegenerative disease involving dopamine loss in the brain. How does she connect those dots? That's where, you have to ask about the mechanism.
And that's absolutely the right question to ask. It requires healthy skepticism, especially with non-traditional theories. The source implies a kind of long-term systemic neurological effect from this chronic strain near the spinal cord, even if she doesn't map out the precise anatomical pathway. Her perspective is very holistic. She seems to view the unrelenting strain and inflammation right there next to the central nervous system's main highway, the spine, as creating this cumulative neurological stress. Over decades, this might manifest in conditions seemingly far removed from the neck.
So the spine isn't just bone structure, it's the core support for the whole nervous system in her view.
Exactly. So the compression isn't just local. It potentially creates this ripple effect, this cascade, that over a very long time could affect central motor control.
And she doesn't just talk about prevention. She makes a pretty astonishing claim about people who already have Parkinson's.
Yeah, she asserts that even for diagnosed Parkinson's patients, if you add consistent, intense treatment aimed specifically at their cervical strain, it could not only significantly improve their quality of life, easing muscle rigidity, pain, but she believes it could potentially abort disease altogether.
Abort the disease.
Those are her words, leading to astonishing results when used alongside standard neurological treatments. Is a very strong claim.
It really underscores how absolutely fundamental she considers this initial subtle neck strain to be. Okay, so if the problem starts so subtly, how does a doctor even spot it before it gets to headaches or tremors, let alone Parkinson's?
Well, in those early stages, she argues diagnosis comes down entirely to clinical skills, diligence, sensitivity, patience. Skills may be less emphasized now with all the high-tech scans. Early on, cervical strain might only show up with really mild findings like specific local tenderness when the doctor presses on certain spots, and maybe a very slight restriction in neck movement, perhaps just in one direction.
So tiny clues. The practitioner has to be really tuned in, really meticulous to even pick these up. They might miss it on a routine exam if they aren't specifically looking.
Precisely. And this leads to some critical, actionable advice for you, the listener, or any practitioner listening. She argues treatment should be started even if standard tests, like an MRI, don't show anything significant. Her justification is basically, this treatment plan would not hurt but help the patient. It's framed as a low-risk, potentially high-reward preventative approach.
Okay. Before we get into the actual physical treatments, she emphasizes something else first, something non-physical.
Yes, absolutely crucial for the patient's mindset. She stresses that before starting any physical therapy, a firm decision by the patient for improvement is very much needed.
Patient commitment.
Totally.
Yeah.
This isn't a passive treatment. It requires consistency, effort, making lifestyle changes. The patient has to be fully bought in for it to work.
Makes sense. Okay, let's look at the specific treatments she found effective, starting with something really basic. Heat.
Yes, but the detail here is vital. She insists specifically on moist heat, not dry heat pads.
My moist heat.
She calls it the most physiological way to relax muscles and calm inflammation. She actually warns against dry heat, says it's often uncomfortable, less tolerable. Moist heat, used consistently, she believes, is genuinely therapeutic. It relaxes muscles in a way medication just can't achieve quickly. It gets at the mechanism, not just the symptom.
Okay, moist heat is step one. What else is in her toolkit?
Number 2 is straightforward. Local massage, applied right to the back of the neck and shoulders, trying to work out that muscle tension. Number 3 involves medication, but carefully chosen. An inflammatory medication, like an NSAI maybe, but it has to be tailored to what the patient can tolerate. This is to fight that underlying chronic inflammation she sees as driving the whole process.
Right. Heat, massage, appropriate anti-inflammatories. And then there's the environmental factor she discovered herself lying on the floor all those years ago.
Yes, a very firm or hard bed. It goes right back to that core mechanical idea. The spine needs consistent, solid support, especially during the long hours we spend sleeping, to prevent strain and compression.
Okay, that covers the treatments. Now, about the healing process itself, she includes a warning, doesn't she? Something important for managing expectations.
Yes, and this raises an important question about what healing actually feels like for the patient. She warns them up front to expect a slight worsening of symptoms in the early stages of treatment.
Getting worse before getting better?
Exactly. She doesn't want people to panic and quit the plan when that happens. She explains this temporary setback is actually the body's natural way of healing. It happens, she says, through the localization of diffuse lesion.
Localization of diffuse lesion. Okay, let's break that down. What does that mean in simple terms?
It basically means the body is actively gathering up all that spread out, low-level inflammatory damage, that's the diffuse lesion, and concentrating it, pulling it into a smaller, more focused area. Why? So it can be dealt with more effectively, repaired properly. So if the damage was kind of vaguely spread across your neck, the healing process might initially pull it all together, making that one spot feel more intensely painful for a short time.
So feeling worse temporarily is actually a sign the body is zeroing in on the problem area.
That's the idea. It's a
Okay.
sign the treatment is actually starting to work as intended. It's managing the psychology of recovery, really.
That's a really useful insight. Okay, finally, the treatment plan includes strengthening, right? Addressing the weak neck muscles that she thinks started the whole cascade.
Yes. The final piece is building strength by actively tensing those neck muscles against resistance. The method is simple. You can do it anywhere. The patient just presses hard with their hand against their forehead, resisting with their knife, then repeat, pressing against the sides of the head and then the back of the head.
Isometric exercise.
Exactly. It strengthens those deep neck stabilizer muscles, hopefully addressing the root mechanical weakness.
Wow. This has been quite a deep dive. We've traced this whole theory right from the source material, starting with that one subtle physical act, kneeling for CPR, through decades of her own experience, both personal and professional, leading to this really cohesive, pretty sweeping theory. We've seen her journey, the sort of aerial roots of the banyan tree, connect this idea of persistent neck strain to everything from simple tension headaches, potentially all the way to influencing something as serious as Parkinson's disease.
And the wisdom she offers, the shade under the banyan tree, it really comes from blending those two viewpoints, doesn't it? The objective physician and the subjective patient who knows firsthand when the standard treatments just don't cut it.
So what does this all mean for you, listening?
Well, maybe it means challenging the idea that chronic conditions are always separate, isolated things. It could mean paying much closer attention to those really subtle clinical signs, that little bit of tenderness, that slight stiffness that modern high-tech scans might just miss or dismiss.
Uh-huh.
And it suggests maybe consistently applying simple, low-risk therapies like the moist heat, the resistance exercises before problems have a chance to really snowball and potentially need much more invasive solutions.
And if we connect this to the bigger picture, I think the author's experience really highlights a central challenge in medicine, doesn't it? Sometimes the hardest part of dealing with chronic illness isn't finding some miracle cure, but actually recognizing the truly subtle beginnings. The things our sophisticated tests might not be sensitive enough, or maybe just not designed, to pick up effectively.
So the question maybe you should mull over is, what subtle symptom are you or perhaps someone you know currently ignoring just because it seems too minor to even mention?